I'm Mary Nafula Haemba. I'm a nurse midwife working in this facility, Kehanja Sub-County Hospital. I'm a maternity in charge. At the same time, I'm a PPH emergency care mentor. It was started in 2019. We were trained as hubs facilities. Those are the facilities that receive the clients. When we rolled it down to peripheral facilities, we grouped them as the spokes. We identified these high volume facilities that are conducting deliveries. We went there, we did the mentorship, the trainings, OJTs. We have been also doing the supervision. Then there was a training that was organized last in May by KMET team. Several participants were selected, they were trained, and we always make a follow-up. They have a register, we make a follow-up on how they are doing. And part of referral, when they call, they have a referral, I always chip in to see if they have done the right thing timely. And we have encouraged them to use the debrief forms so that we can fill the gaps. And the most important thing, when we go to the facility for mentorship or training, we tell them that when we do assimilation, let it be real. Let them relax. It does not impact on their salary or on their job, because when they see these senior officers, they will tend to shy away. So we have encouraged simulations in their facilities to be doing the CMEs and simulations. And initially it was a nurse's activity. But for now, even clinicians have picked it and everybody has embraced it.
It is unique in the sense that it is one of the first programs that the professional body COGS has come in to also give support and that team approach. So currently I'm the SLO for the program. So we are able to work as a team down here with the KMET team and also the health workers within the county, and also give feedback to COGS and FIGO through that channel. Basically what we've been emphasizing on through this program is the standardization in the management of postpartum hemorrhage. Yeah? Before the program was rolled out in the county, it was kind of haphazard approach in terms of management of patients who get postpartum hemorrhage. But using the bundle approach, we are seeing standardization in terms of management of these cases of postpartum hemorrhage. Everyone now knows that when a mother has postpartum hemorrhage, the first bundle has become like a song in the county, and it is a song that everyone is singing up to the lowest tier facilities in the county. But right now, the number of referrals, I would say, have greatly gone down, because most of these patients who have postpartum hemorrhage, they're able to give the first bundle, and most of them, they respond to the first bundle. So which means that they don't have to put a lot of burden at the county referral hospital. So the few cases that we still get, by the time they are coming, these are patients who already have IV fluids running. The crystalloids have been given, they have IV access, the crystalloids are running. These are patients you would find they've even grouped and cross-matched. And in some centers where they have the mini blood banks, they even start transfusion. And then a good number of them also come with the UBTs already in situ. So the only cases that we are getting are the cases that have not responded to the first bundle.
So there is this patient who was brought in. It was a referral from Mariwa Health Center, and the patient had retained placenta. On arrival, the patient had really bled, and the patient was pale. So the MO on duty was at that time in theater doing a cesarean section. So I happened to be on duty with my colleagues. So when the patient was brought in, we went in and removed the placenta manually. Though the delivery of the placenta was difficult because it was at their end, but we removed it manually. And after ascertaining that it was relatively almost a complete placenta, we gave misoprostol and tranexamic acid. We did the first response to the full. We fixed a second line. We took samples for cross-match. Then we gave tranexamic acid. And the patient was still bleeding. And on assessment, the uterus was not well contracted. We suspected there could be retained products of conception. So as we were waiting for the patient to be stable and do an ultrasound maybe and waiting for the doctor, we were able to apply a UBT that helped stop the bleeding, and the patient was stable and was able to wait for other interventions. So when the doctor came, found the patient already stable, and there's nothing much he did because we'd already even ordered for cross-matched blood. So his was to accept to our plan of management, and we transfused the patient, and the patient was okay. The patient was happy, we were happy, and she was discharged.
When I evaluate myself, we used to waste resources. We used to give oxytocin even up to 100 international units with no effect. Sincerely, after 40 international units, and you are adding oxytocin, it will not be helpful. You move to another one. Tranexamic acid was a challenge. We used just to hear it. It's used in a theater. But now on the ground, we know how to administer it. Then there is a late referral. Most of the clients, in fact, used to die, in fact, before being received. But with a bundle, now that we know what to start with or when to stop this, it assisted me. For example, you are using that bundling care. Things are done in a shorter period. It will reduce the blood loss. Like in 1 minute, a client is losing naturally 100 mils per minute. But when you bundle, it will reduce even to 10 mils per minute. So it will reduce the necessity of blood transfusion.
Initially, even for doctors, before I was brought on board as the SLO. So most of the time, when we have a mother who has a postpartum hemorrhage, the first response, you would find only midwives would rush to see this woman. So by the time a doctor is called, the doctor is just called to take the patient to theater. So this one has changed a lot. So when we have a case right now across the county in the health facilities, when a woman has postpartum hemorrhage, what happens is that the whole team is called, the rapid response team is called. And there's always a team lead. And most of the time the team lead is either a clinical officer, a medical officer, or the obstetrician gynecologist. So it is teamwork. As we are able to bundle these cases as a team. We've also brought on board the private facilities. So one thing we've done is that we have a WhatsApp group of all the doctors, be it in the private, faith-based or the government facilities. So through this WhatsApp group, we are able to work as a team. So I've circulated my contact across the facilities. These medical officers have also been trained on managing of these cases using the bundle approach. Yeah, so whenever they have a case that is refractory, they are able to even get me in time, contact me. So instead of wasting time referring the patient to the county referral hospital, so I'm able to rush to these facilities. Now within the government facilities, we've also introduced what is called reverse referral. So instead of the mother bleeding all the way from Timaru or all the way from Kehancha, the health worker is taken there. So in this case, the obstetrician gynecologist, if the case complicates, then there's a vehicle that is just designated for that. So they're able to pick me from the hospital at the county referral hospital, or even from my home in the night, and then we rush there and sort out the case, rather than wasting a lot of time referring the patient to the county referral hospital. So we've saved many lives by just doing that. And that one life that you're able to save really makes a difference in your practice. And also it has an impact even in your social life. Yeah, we've seen health workers going down into depression when they lose their patients and all that. You get stressed. But saving that one life also saves your life as a health worker. Great impacts through this postpartum, management using the bundle approach.